Hi, guys. That is such an inspiring talk to follow. And there's going to be a lot of things that Sarah said much more eloquently and from lived experience, which provides so much more depth. So there's going to be parts of my talk that she just did for me. So I'm going to concentrate and talk a little bit more about the experience of a provider and what the continual process of digging myself out of my own unconscious bias has been like with the gift of getting to work with hypermobile patients. So there's whole slides I'm just going to fly right past because Sarah's lived experience gives so much more depth of emotion. So I want to start with a visual of some bonsai plants because I kind of view myself as a bonsai plant, and I view all of the patients that I'm working with and the other healthcare professionals that I work with, that we have all been, through our own growth and development, pruned and shaped by our experiences and the things that we have encountered and the things that we've been taught. And this doesn't make us a bad tree. It doesn't make us an ugly tree. It makes us all living creatures that have been influenced by our environment. And with that, every single one of us has unconscious bias. It's the process of discovering why it's there, what got put there, why it got put there, and then actually like excavating it out, like getting a shovel and finding it within myself, that I have really grown to get to know myself in a way that I never would have without getting to work with a disabled population. So there's been a lot of anger and grief and sadness and beauty of getting to really know the stories of people that have suffered. So what shapes these bonsai trees? I'm trying to look at the picture and pick which one I feel like best represents myself. I'm not sure. But it's really how identities and the identities that we hold can collide. So that includes our gender, our body size, our socioeconomic status, our disability, race and gender identity and age. And all of these come together to shape how that tree has been influenced and grown and pruned throughout somebody's lifespan. I think what we're learning is that each of these can share a different sort of size of the puzzle, and that race and disability together often leads to watching and witnessing incredible levels of oppression within my patient population. And with that, I want to read this quote. This is a researcher at the University of Michigan who has termed a biological process that she calls weathering. And I have started to talk about this more with patients of like, does your body, does your soul, does your psyche feel weathered by what you have experienced? And she puts it so eloquently, I don't want to try to steal her words, so I'm going to read her quote. Ideologies that sustain racialization and other forms of cultural oppression, racism, sexism, classism, ageism, xenophobia, homophobia, ableism, she didn't put it in there, but I have to add it, have real measurable consequences for health beyond the economic and educational inequalities they create. Pervasive racists and classists activate biological processes that wear out the physical and mental health of people. And thus we have weathering. I keep thinking, listening to all these talks, we've put so much focus on the psychological harm of misdiagnosis, the psychological harm of medical gaslighting. It's my hope as a provider and researcher to start to quantify the biological, physiologic harm of oppression. So with that, I'm going to make a public call for a vision of research that I have that's going to take many teams of people to do this correctly. And I'm in the right place to make a call to action like this. So I envision creating a validated tool to actually quantify the clinical associated traumatization, almost like an ACE score or some of these disease activity scores that we'll use to create an actually like how much cat has somebody, does somebody have like a kitten on their lap, or have they had like lions and tigers level of clinical associated traumatization? And once we can quantify it, then we can start to look at some of these other validated tools for severity of pain, or look at the Compass 31 for the severity of autonomic dysfunction. Because I think we need to start building from the provider side of this a much stronger understanding of how much harm oppression is causing to our patients physically. That we are both at the cause and the effect of our patients' abnormal physiology. I'm trying to get rid of the word normal from my vernacular. Specifically, I want to talk a little bit about ableism. We have been talking around and about ableism without calling it out directly for the last 2 incredible days of lectures. So I want to call it out directly. And before I go to the next slide, it's the end of the day. You guys are probably pretty snockered out right now. I just want to hear, like, you guys can shout at me and I'll say it through the mic for the folks at home, like how you guys think about the term ableism, what you feel like that term both like means, but maybe more importantly, what it means to you.
It means it's like racism, only instead of the race, it's people with disabilities.
Okay, so she was saying it's sort of like racism, but rather than judging a person's worth based on the color of their skin, I'm putting a couple extra words on there. You're basing somebody based on their level of ability or disability. Any other like definitions or ways it impacts you? And you'll have to really scream at me, I'm sorry. Great, so there can be, she was saying that like people staring at you or making comments when you're using a mobility device. That to me is a behavior that's feeding out of ableism. And what the ableism is that's underlying that behavior is an assumption that somebody who's using a mobility device is broken, that they're a less important participant in our culture, or even that, you know, they should feel shame about going out in public, having the audacity to use a mobility device out in public. Any other ones that people want to put out? I heard the disregarded, disrespected, and not important. Great. So that not important is so, the not important is so important. How many times can I say that in a sentence? Because what that speaks to is a very human process that we all engage in, which is stratifying people into some kind of social order of those that are better and those that are less than. And that feeling of not important that somebody with a disability has is the direct impact of ableism. So this, I think, is kind of the most succinct definition that I could find, which is it's a belief that people with disabilities, that they need to be fixed, which means that there's an assumption that you're inherently broken, AKA not a full human, right? Or you can't function as a full member of society. I put in here some really lovely, eloquent quotes about ableism. I'm going to actually read. This is Talila Lewis, and they maintain a working definition of ableism that gets updated on a nearly yearly basis. So this is kind of the updated definition. It's a system of assigning value to people's bodies and minds based on societal constructed ideas of normalcy, productivity, desirability, intelligence, excellence, and fitness. These constructed ideas are deeply rooted in eugenics, anti-Blackness, misogyny, colonialism, imperialism, and capitalism. This systemic oppression that leads to people and society determining people's value based on their culture, age, language, appearance, religion, birth or living place, their health or wellness, and their ability to satisfactorily reproduce, excel, and behave. And you do not have to be disabled to experience ableism. Although when we look at those intersecting identities, ableism and age are the two that are most likely to be experienced by everyone over the course of their lifetime if they are lucky to live a long life. So with holding a marginalized identity like disability that has been cast in our society as less than, we often will see people in the medical community. So I'm kind of going to speak to this from the medical side, because I know that you as patients experience this differently than how I witness it as a provider, that oftentimes a doctor and the doctors that I work with are very hesitant, or even, that patient's disabled, or they're throwing in the towel and they're gonna apply for disability. And there's a lot of negative connotation of just not only accepting, but celebrating somebody's disability. So with that, the term has shame, just saying the word disability. And we tend to come up with a lot of euphemisms when we feel uncomfortable saying a term. So differently abled or special needs, or handy-capable. These are all sort of euphemisms dancing around the discomfort of disability. So I'm not going to make anybody raise hands, but I am kind of curious, and I hope to grab me and have a conversation with me about what it was like for you as a disabled person when you first started to try on that identity, kind of like putting on a pair of pants and like slipping it in and like walking around in the disability pants and being like, oh, this is really uncomfortable. I really don't like this. Both in your internal experience of wearing those pants and then going out in the world and having to interact with the world in those pants. It's my perspective from a provider that the discomfort of putting on the disability pants internally and externally, trying to interact with the world in them, is actually part of what is causing physiologic harm and making my patients hurt more and have more actual physiologic abnormalities related to their disorder. So I'm not even kidding. Sometimes patients are like, okay, well, what's my diagnosis? And I'm like, okay, your diagnosis is the patriarchy. We need to surgically cut it out of you. I don't have the tools yet, but I'm gonna build them, and I'm gonna build them with the community that starts to recognize that colonialism and capitalism and the patriarchy have built a system that is causing disease. And your soft, beautiful, receptive EDS bodies, that's where it gets written in your body, and we gotta get it out as a team. So thank you for letting me come and talk to you about about ableism. There's kind of three general models of disability. I personally need my own, I have my own surgical excision that needs to happen, which is existing within a medical institution that is deeply rooted in the medical model of disability. It's pretty challenging, I'm not gonna lie, where really disability is viewed as an impairing brokenness, and that the body is broken and that it's our job to fix you. I've kind of put in some pictures of terms that can sometimes get used, like, oh, this person is confined to a wheelchair, rather than this person utilizes a mobility device to get out and live their life. There's little subtle things in language that we start to see when we like wake up to the matrix of these models of disability. We also have the social model of disability, which I think impacts a lot of EDS patients as well, that basically says, you know, if we had a more accessible world, if the world had been both designed and built and thought up and dreamed and included the brilliant minds of disabled folks, that accessibility would improve. And therefore we could be folding in and including disabled folks in so many more parts of our world. There was just a really great radio lab about building a space program specifically for disabled folks and looking at actually the benefits of sending a person who is blind or hearing impaired, or what kind of benefits putting them onto a team would have when the fire lights up in the cockpit and nobody can get around to put the fire out, and you have a blind astronaut, they can put the fire out, right? So not only is this like, oh, wouldn't it be cute if we had a couple disabled folks on the team? This is, you put disabled folks on your team and you are gonna build new and beautiful structures and programs and new technologies. This isn't about like inclusivity to like check off a box on a number. This is inclusivity because it's actually what's going to create a world that maybe we can survive climate change. Because I can tell you, it is not the undisabled folks that are going to solve climate change, because it's not their bodies that are passing out and breaking down under the oppression of heat. So I have that to say as well. Lastly, I want to talk about more the human rights model of disability, because this incorporates that this isn't just about accessibility. This isn't just about building systems of inclusivity. This is actually recognizing that disabled people have always been here, they will always be here, and they're actually part of the beautiful spectrum of humanity. So you are not a mistake. You are feeling the deep, painful effects of a culture that has wanted to disappear any kind of marginalized identity. Disabled, we were all, I'm going to talk about this tomorrow in my lecture too, but one of the real problems of sort of natural medicine or integrative or functional medicine is that the underlying belief is that like, if you just eat the right diet and you do the right exercise, like the body is designed perfect. So if you're not perfect, there's some mistake. There's a mistake there. And I say human bodies were never designed to be perfect. And it's that imperfection that actually is so beautiful. And when I started to realize that my own unconscious bias, the effect that that was truly having was on separating me from experiencing and loving the beauty of humanity, there's a true sadness there of the separation that these things perpetuate. I'm not going to talk about intersectionality because I've put some of the discussion about this, and we've been talking about these as well. This is a topic that has not been touched on, so I do want to take a couple minutes on this slide. that oftentimes, I started to notice this maybe a year and a half ago, how pervasive we use military language when we're talking about the body and talking about health. Some of the examples that I started to notice were saying things like painkillers. Patients asking for painkillers, we're putting this idea of kill. Doctors always referring like, oh, I got it, like I worked my time in the trenches. There's this very colonialism, military language that we often end up using. It came to a fruition watching my mom go through the process of cancer last year. And all these inspiring, meant to be inspiring cards of being the cancer warrior. We use this term in the EDS community too, of being an EDS warrior. Now, I'm not saying that it's not the right term to use, because for some, it is a really empowering persona to take on the hero's journey and the warrior pants. But that may not be what is right for you. And unfortunately, I think when medicine and the practice of medicine becomes entrenched, I guess that's another military word right there, becomes entwined with these war metaphors, health starts to be viewed as something you just need to fight hard enough for. And if you're not better, then it's somehow seen as a failure personally on the patient, or a failure on the doctor. As we're trying to understand, like, why are doctors experiencing burnout and leaving the profession in sort of troves, I think about this. Like, if it were my job every day to go and fix EDS patients, you guys, I would be mentally and emotionally and spiritually screwed, because it's not my job to fix you. It's my job to support you. And if I'm viewing this as a thing I just need to like fight harder for in order to fix somebody, I'm gonna fail. That would, for me personally, lead to true and utter burnout. I'm not gonna talk about health cliches. Most of them basically say, if you're not healthy, you're a piece of shit. That's what like most health cliches out there are out there to tell you, and that, you know, without health, you've got nothing, which is garbage. How I start to see ableism showing up in healthcare, we've already actually talked a lot about these, but one that I experience, and I always call in, I'm gonna start using the call in instead of call out, but call in with my patients, is a lot of language that gets used both on the clinical side, but also within patient visits that implies that caring for patients is a burden. I try in every visit to assure my patients that they are not a burden. It is the system, the medical systems of trying to care for complex patients, that is the burden. It is not your needs. It's the infrastructure that was never designed for complexity. It's an infrastructure that's designed for an algorithm of your blood pressure is this, here is your drug, or your leg is broken, I will fix it, and on you go. We've talked so much about gaslighting and red flags of gaslighting. What I wanna call in to you as a group, are some of the ways that I see this starting to show up in visits. 1, 90% of my patients apologize for their symptoms, or they apologize for asking for things like, I'm so sorry, I need you to fill out this FMLA paperwork. I'm so sorry to ask, can you do this disability placard? And I'm like, this is literally my job. Like, I wanna do these things for you. I envision an accessible world, and that means that I am gonna like joyfully fill out your forms. You asking for things from me is not a burden. You having a lot of symptoms is not a burden. Now, I recognize that I'm not like other providers, right? Because So many other providers are entrenched in these fix them mindsets where when a patient comes in with 30 symptoms, that's going to feel to them like a burden because they don't have any tools to fix it, and they think it's their job to cure you and make you better. I am negative 40 seconds, so I have to wrap it up. Very last, these are kind of more things that I try to work with teaching providers, teaching medical students, and doing trainings for our ambulatory nurses is starting to reframe language. So rather than saying like, are you feeling better? I ask how somebody is, or are you back at work? There's an assumption there that if you're not, you should be trying harder, which is what is that individual's goals? Maybe going back to work is not their goal. Are you dependent on fill in the blank versus what tools do you use to support you? But most importantly, and this one has been said now, this is the 15th time in 24 hours, like I'm gonna believe you. This quote, I have to read it. I know you guys told me to wrap up a minute and 41 seconds ago, is that the trouble, once you have seen it, you can't unsee it. And once you've seen it, keeping quiet, saying nothing, becomes as political an act as speaking out. There is no innocence in either way, you're accountable. By Arundhati Roy. And I just want you guys to know that I'm gonna stay accountable and continue to have the hard conversations within medical systems that are just so very uncomfortable because they are really coming up against so many types of unconscious bias that affect disabled people of all colors, all sizes. And this talk was very much made possible by time and labor of disabled folks. So my gratitude to all of my patients, all of my friends and colleagues who have helped me learn, and thank you.